Okay, so again, that cerebrocerebellum, um, gets a lot of information right from the cortex, and then actually sends out a lot of information to the cortex. So it's kind of a closed loop. It's like a circle. So let's take a look at the next slide. Um, I went the wrong way. Sorry. Um, so again, this just shows kind of a graphic to show the information coming in from the cerebral cortex into those lateral hemispheres of the cerebellum or the cerebrocerebellum, and then the output is also going back to the cerebral cortex. So there's that loop. That cerebellum's kind of in constant contact or communication with the cortex, and it's constantly taking in information um, from the cortex and then sending information back to kind of weigh in on what the brain thinks it's plans to do and then what it's actually doing. So when we have lesions here in this part of the cerebellum, we see problems again with fine movements. We also see problems with dysarthria, slurred and poorly articulated speech, and we see because of those fine movements, we're also seeing hand and finger ataxia, which is kind of those decreased coordination of those fine finger movements. So we're going to take a closer look at some of those clinical symptoms post-cerebellar lesions in a minute. And again, here's a picture of just showing us how close these sections of the brain are in contact with each other. You've got the cerebellum, you can see the cerebellar peduncles, you can see how they're sitting really close to the medulla, the brainstem. So if we have a lesion in this area, a patient might be suffering a variety of symptoms, right, in their stroke, or if they have a tumor in this space. It can really be catastrophic because it's really taking out a lot of these parts of the brain that integrate a lot of information coming in and out of this the cerebral cortex, and it can have a variety of impacts. So again, a big clinical symptom whenever you hear the word cerebellum, and if there's a lesion there or pressure there from a tumor or some head injury that caused damage to the cerebellum, ataxia is one of those classic clinical symptoms, and it's a movement disorder. So we imagine that as PTs and physical therapist assistants, that is immediately something that we are concerned about for our patients. Why? If you've got movement disorders and if your balance is impaired and your coordination is impaired, we're concerned about safety, right? Concerned about maybe falling. So again, ataxia itself is a movement disorder that's common to all cerebellar lesions. It just comes out a little differently depending on specifically which section of the cerebellum is injured or damaged. So ataxia is described as impaired coordination. It's not caused by weakness or spasticity or contracture. So the patients that have ataxia have normal strength. They don't have spasticity or contractures. It's not related to those types of things. So, which means if strength isn't an issue, then working on their strength isn't necessarily going to help the ataxia, right? Because that's not really a problem. That's not really what's causing the symptom. So we have to really focus, if we can, on coordination and other types of treatments. We also see with ataxia uncoordinated kind of voluntary movements. So when the patient's trying to move, the movements are jerky and inaccurate, but of normal strength. We also see patients with chronic alcoholism that tends to really impair the anterior lobe of the cerebellum, that's spinocerebellum. That tends to be the part of the cerebellum that gets damaged with long-standing alcohol abuse. That becomes damaged due to poor nutrition, and we can see ataxia resulting from alcohol abuse as well. So now so generally ataxia is something that we see with cerebellar lesions. So now we're going to take a look at when you have very specific lesions in each part of the cerebellum, what we see. So in the vestibulocerebellar lesions, when that part of the cerebellum is damaged, which is again the vermis and the floccular-nodular lobe, we see nystagmus, which are abnormal eye movements. So in this case, the nystagmus is caused by damage to the cerebellum. Now, we talked a little bit, and Aaron asked a question last week about nystagmus. So there are several different types of nystagmus that are caused from a variety of things. And some nystagmus is actually considered normal. And we use the word physiological nystagmus if it's your eye is having a kind of a normal response to kind of the environment moving. So there is normal nystagmus, but here, of course, we're talking about abnormal nystagmus or pathological nystagmus. And that is kind of when the eyes have a difficulty focusing on things in the kind of visual field, and the eyes will move and present in a variety of different ways with abnormal movements. So the neurologist will be focusing in on testing nystagmus. Sometimes we see nystagmus with peripheral damage of the vestibular system. Like someone asked the other day about, benign paroxysmal, like vertigo. You can see some nystagmus with that as well. But here we're talking more about kind of central nystagmus. So nystagmus is caused by this lobe in the cerebellum. It can also be caused when the vestibular nuclei in the brain stem is damaged. But here we're talking about kind of cerebellar nystagmus. So that's what we're going to focus on. And that's, again, that nystagmus is kind of an oscillating movement of the eyes, and that can indicate a lesion of the cerebellum or other areas, but today we're talking specifically about the cerebellar nystagmus. With these folks, we also see truncal ataxia, so ataxia of the trunk, and that's when our patients have difficulty maintaining sitting and standing balance. Their trunk and their head wobbles while they're trying to remain steady. So again, you can imagine if your patient's trunk and head is wobbling while they're trying to remain steady, what clinically could you see? They might have, if their head and trunk are wobbling, they're having a hard time maintaining kind of steady vision, right? Or steady gaze. They're going to have difficulty with sitting and standing balance. So what might you do as a therapist? You might need a second set of hands, right? You might need to put them in a chair with a back instead of sitting on a bench with no back support, right? They might be unsteady. So keep in mind that you're going to change the way you work with a patient depending on, regardless of the diagnosis, whatever symptoms you're seeing, you've got to make sure the patient is safe. And we'll talk more about that when we get next year, when we talk more about, specific lesions and specific neurological injuries. So spinocerebellar lesions, again, we remember that's the part of the cerebellum that helps with gross limb movements, that paravermal region. So with these folks, we see an ataxic gait, which is wide-based. They're unsteady, they're staggering, they kind of look drunk when they're walking, they veer. You can also see with these folks limb ataxia, which could be lower or upper limb ataxia, and that results in dysdiadochokinesia, which is that inability to rapidly alternate movement. So we test that in the hospital by having patients put both hands on their lap, and they rapidly supinate and pronate the hands to check whether or not they have kind of that gross coordination of movement of the hands. We also can test dysmetria. We test that with that finger to nose test, that inability to accurately move that intended distance. So neurologists will do a finger to nose test and have the patient tap the tip of their nose and reach out and tap the physician's finger for dysmetria. So we have an inability to kind of move to a very specific place or distance. Sometimes with these folks, we see action tremors, which is a shaking of the limb during active movement. So if you're reaching for something, that limb gets shaky and inaccurate. We also see dysarthria. Oh, there's a little typo there, dysarthria. That is that slurred poorly articulated speech. We also see cerebrocerebellar lesions, which that's a part of the cerebellum that helps manage fine movements, that the lateral cerebellum. So we see dysarthria here as well. We can see slurred, poorly articulated speech. We can also see hand and finger ataxia, which is decreased coordination of those fine finger movements. So for the last two slides, I had attached a couple of videos that I thought would be helpful. This first patient has cerebrocerebellar ataxia, and you can hear her dysarthria, which is connected to those cortical brainstem tracts impacting the cranial nerves that affect the muscles of the face. And you can also see some inability to move those fingers in a coordinated manner. So you can watch that video. And here's a video of a patient with spinocerebellar ataxia, which again, you're going to see problems with his, impact, the cerebellar having, impact on the medial and lateral reticulospinal tract, which facilitate postural trunk muscles and those gross limb movements during walking. So you see the resulting symptoms from that ataxia, and the vestibulospinal tract as well. So, you'll see him doing, I think they're doing kind of that heel to shin test, showing some of the discoordination against gravity when the patient is trying to do that. Slide his heel up his opposite shin, and that's kind of a classic lower body coordination test. So there are a couple of videos there just to help give you some visuals, but to also continue to take a look at other YouTube videos if you need more kind of visual ideas of what these patients actually look like, and imagine kind of treating them. And there are some different treatments that we'll talk about. We'll talk about that next year too when we get into the actual treatment of these folks. But you can imagine, take a look at how they present. You can imagine how challenging, it is for them to act. If you're that discoordinated, how challenging it is for you to complete motor tasks.